Good morning, everybody. And it only feels like yesterday that we were standing up here doing the first of the knowledge exchange events associated with the SYNERG-IE program. So it's lovely to see so many familiar faces back in the room again, that we've met again, of course, during the course of the year. So my name is Owen, and I am the clinical lead on SYNERG-IE, and Mags is
patient representative.
So we are co-chairing this this morning. So we've a packed schedule that we'll try our best to keep on time and get everyone out at lunchtime. And just at the very start, we'd just like to introduce Michelle, who's obviously the overall lead for the project, just to give us a brief few words about the day. Thank you very much. So it's Prof. Michelle Flood.
So good morning, everybody, and it's great to see so many people here, and welcome to everybody online. We're delighted to have a mix today of both patients and people living with Sjögren's, their family members, some friends, and also healthcare professionals, because the way that we're going to make things better is by working together. Healthcare professionals have some expertise, but patients hold that really important expertise that we'll never understand. I know about Sjögren's, I'm a pharmacist, I know about medicines, but I don't know what it's like to live with Sjögren's. So without you helping us understand what that's like, we won't be able to make the best efforts to improve everything together. I'm particularly grateful to our partners in Sjögren's Ireland to see everybody here this morning. This project would not be possible without their support and input. So SYNERG-IE is a programme that is run here through RCSI with collaboration from TU Dublin, the National College of Art and Design. We have lots of collaborations across Trinity, UCD as well, but the main goal of what we're trying to do is to address 6 challenges that we've worked together with patients to identify. So we've learned from working with Sjögren's Ireland and many of you over the years that we need to understand and improve how medicines are prescribed for people living with Sjögren's. And that's not just Sjögren's medicines. There's lots of other medicines that we take as we get older and we, develop more other illnesses that, might not go best with our Sjögren's, so we're going to work on that. Our second challenge is to formally report patients' experience. I think, there's so much experience, but unfortunately the time hasn't yet been taken to capture that and to share it with others, to make everybody aware of what it's like to live with Sjögren's so that the research can start to, kind of influence policy. We've learned from you all that we need to educate current and future healthcare workers, and that's really important because we're really delighted to have experts here today in rheumatology. So we have Owen and we have Dr. Natasha and Dr. Emily. But a lot of the healthcare workers that you meet in the community in particular may not know that much about Sjögren's. So the first people you meet need to know a lot about Sjögren's. So to find out what it is, to be able to detect it earlier for you and to refer you on to specialists sooner. We don't currently have any guidelines nationally or policies really related to Sjögren's care. We have lots of expert clinicians and we hope to be able to draw on those experiences to co-develop with patients some guidelines to help support use, particularly for people you meet in the community. A lot of you won't have Sjögren's only. You might have something else. So you might have lupus or rheumatoid arthritis or another disease that goes along with your Sjögren's. So we need to figure out how do those things interrelate together. And then what's really important to us is that we partner with people living with Sjögren's throughout, because your expertise is critical. And as I always say, we will need you as we go forwards to tell us, to let us know what it's like so that we can include all of your experiences in the research that we do, and when we start to talk to policymakers to make sure that that's all incorporated. And I just want to say a very big thank you. It's a very big team. These are just the day-to-day people. You'll meet lots of our other collaborators here today. So I'm overall in charge of the project. And we're very grateful to the Health Research Board, who've given us €2.5 million to work on this. So it's not an insignificant amount of money. And we're very committed to making every last penny of that count towards improving care. So myself and Frank and Owen are the 3 leads. Sjögren's Ireland are our partner and have been really important to us throughout. Very grateful to Dr. Nikki Dunne, who you'll hear from in a little while. She's a program manager. Grania unfortunately can't be here today, but she's a critical member of our team. She works with us day to day, and she's a patient representative researcher. Make sure the patient voice is included throughout. We have our wonderful postdoctoral researchers, Dr. Claire Campbell and Dr. Constanza Saka. And just to give you an idea, so Claire's background is nursing, Connie is a dentist, Nikki's sociology, myself and Frank are pharmacists. It's a really interdisciplinary team because we know that we have to look at this together. We have Alana, who's a designer, and a huge thanks to Alana and Katie and Jessica in particular for all their work on today. And then we have Jessica and Katie, who are both PhD researchers. And a critical part of our team, and Mags is one of our members, is our public and patient involvement panel. And what that means is that they influence decisions that we make on the project. So we don't take steps without making sure that our patient partners are happy. And that's really important to us because the last thing we want to do is start to do things for research's sake. We want to make sure that what we're doing is important to you as well. So this is a slide from Grania, so I just want to credit her with that. But what we're hoping is that after we've spent 5 years working on this, that primary care healthcare professionals will identify your symptoms quicker. So they'll notice that the symptoms are more likely to be something else. And the healthcare professionals we're working with include dentists, optometrists, pharmacists, GPs, physiotherapists, because we understand that you might present to one of these people with your symptoms, and if they can recognise it quicker, that's more useful. And Dr. Katrina Barrett is here from TU Dublin. She's an optometrist, and she's one of our co-applicants, and it's very important as well. If you're kind of diagnosed, it's confirmed as quickly as possible, notwithstanding it's complex, and Natasha will explain a little bit more about that. But that you're advised then to contact Sjögren's Ireland for some support, because we're aware of the importance of peer support and advocacy for you. You'll have a multidisciplinary team and everybody will be aware of the disease and how to manage it, and that'll be informed by guidelines. And then we'd love if you all had an opportunity to feed into research, and Nikki will give you some opportunities for that later. So just a whistle-stop tour of the 5-year plan, but we're year 2 now, so we're really excited to see, as Owen said, so many of you back today. So I'll hand back to Owen now. Thank you.
Thanks very much, Michelle. Just a few housekeeping items before we start. We're going to aim for a coffee break around 11:15. We'll try our best to keep everyone on time, but naturally there probably might be some questions and things. We are scheduled to have a panel discussion at 25 to 12 for kind of half an hour or so, and I think that's probably where we'll do a lot of the discussing and questions at that point. As ever, we'll kind of touch on the general themes and the management of Sjögren's, but we won't be able to be in a position to kind of answer specific questions around patient care, if that's okay. So without further ado, I'm just going to introduce you to Dr. Nikki Dunne, who's going to give us a brief snapshot or findings of the SYNERG-IE Photo Voice study to date. Thank you very much.
Thank you, Owen, and thanks to everybody for coming on a cold morning towards the end of November. We really appreciate you all turning up in person, and for those of you online for tuning in as well. So thank you so much. So I just want to talk to you about one of the studies that we have undertaken as part of that work package, or the challenge that Michelle talked about around the formal documentation of experiences of living with Sjögren's. So this is one study within one of our work streams, and it's very, very powerful. I hope you'd agree. So this is the snapshots of Sjögren's study. So some of you might have been here actually in July to mark World Sjögren's Day. We had an exhibition of the photo voice, some of the photographs, and today I want to talk to you through the academic findings of the research. So we used a method called photo voice. It's quite a simple idea. People use photography and storytelling to show what life looks like for them. And in this case, we asked them to show about what their experience was of living with Sjögren's. So we worked with 11 women aged from their 40s to the 70s. 10 had formal diagnosis of Sjögren's, 1 was undiagnosed. And the project was co-designed with our patient researcher, Grania, who's part of the team, and we also had members of our steering panel, so Sjögren's Ireland and our PPI group informing it. Together we made sure that the process worked for people living with fatigue. We worked online, we kept the sessions short, we gave options to contribute via email or over the phone, and made it very clear that participation was flexible. So participants took part in short training. They took 5 to 10 photographs over a 2 to 3 week period over December, January last year. And then they had a one-to-one interview with a researcher. And following that, then they took part in small group workshops where they shared stories and they reflected on the meaning behind their images. And like I said, we held the exhibition on the 23rd of July here in College Hall in RCSI, but we also had a mini exhibition in Beaumont Hospital on World Sjögren's Day, which was really important for us to bring the findings and bring the patient experience into the hospital as well. And that's something that we'd be keen to kind of continue. So what do the images and stories show us? So when we look across all of the photos and the interviews, some strong themes began to emerge. Now, each person's experience was unique, but there were some common threads. So I'm going to talk you through some of those. So living with invisible illness. One of the most powerful themes was invisibility. Although there are some visible signs like rashes and swelling that participants took photographs of, Sjögren's, they communicated, was experienced very much as a physically invisible disease with fatigue, body pain, brain fog, organ deterioration, all of those things that just can't be seen. And participants shared that tension of how they might look fine to others, but feeling completely drained and unwell inside. And this person took this photograph of a jigsaw to communicate their experience of living with brain fog. They just said every time they saw a jigsaw puzzle, it reminded them of how much they forget things and how confused they can get. And many also felt that the invisibility of sometimes invited doubt and suspicion. So this woman just talked about her family members, extended family members, saying there's nothing wrong with her, she looks great. But then when people don't see how unwell they are, that they don't necessarily get it. There was a lot of pictures where people were trying to communicate what it's like to live with fatigue, which is obviously very difficult to communicate. But this person took a photograph of the sun setting and just how difficult just to communicate the profound fatigue and the energy seeping out, and how it's something that you just can't stop. It just happens to the body, and all you can do is just stop and rest. The paths to diagnosis for our 11 women ranged from swift to multi-year and multi-speciality, and the majority had lengthy delays. So for those who had a quicker journey, there was usually a healthcare professional there who recognised the pattern and took it seriously, but the longer routes were marked by, it being misattributed or initially investigated as related to menopause, anxiety, lupus or ageing. And participants felt that there was a tendency to reduce what is a complex and systemic illness to something minor, like it's just dryness. Again, they felt like they weren't necessarily believed, and that led to second-guessing themselves, especially in the pre-diagnosis stage, asking themselves, are they going mad? Are they just imagining this as in their head? And then for many, diagnosis did actually bring relief, but it didn't necessarily resolve their challenges, and they felt like they were still minimised their symptoms as just dryness, and the healthcare professionals didn't necessarily understand what Sjögren's was, and they weren't necessarily knowledgeable. So even after diagnosis, there was a sense that they were still seeking validation from their healthcare professionals. This image here then is a picture that someone took to just communicate the experience of feeling like they were rushed in and out of appointments in the public healthcare system, never really getting answers. The entrance was far away and the exit was they were swiftly exited out. That link to that was the challenge of navigating a fragmented healthcare system. People talked about moving between different specialists, and not necessarily with their specialists, not necessarily, they didn't feel that they'd seen the whole picture, and they felt like they had to join the dots themselves. So there's an image here where this person described herself as feeling like her experience as being like this tree, where she never knew what symptom was related to Sjögren's, what symptom was related to something else, and then that she had to do the work of joining the dots. And this thread of uncertainty was common for most of for the women. Now, also important to say that many noted excellent healthcare professionals, those who were knowledgeable, open, and willingness to learn about Sjögren's, even if they didn't necessarily know so much about it. And there was a lot of comfort in having that type of support. Living with Sjögren's isn't passive, as I'm sure many people in this room know. It's active, it's ongoing, it's work. There's a huge amount of effort involved in managing the illness. So people took photographs of calendars, planners, medicine boxes, eye drops, over-the-counter products, food, all the tools that people rely on to try to stay well. They described keeping diaries, lists, folders, using apps to track medications and symptoms. They also described the pacing and trying to look after themselves as key to staying well, and that rest and self-care wasn't seen as a luxury but essential to their well-being. And that constant vigilance and work to try to stay well was described in one of the workshops as running to stand still. So it's just the constant effort involved in that. And all of that came at a cost. So several people talked about the financial strain of paying for private appointments or buying products that help them function that weren't available through the drug payment scheme or other schemes. They felt like they were just paying a lot out of pocket. And the cost wasn't necessarily just financial. There was a huge cognitive burden as well. It took time and it just required a lot of administration too. Participants then also shared how Sjögren's has reshaped their lives. So some described really big changes like stepping back from work and career progression or changing family planning, like really big decisions and impact on their life, but also changes to more everyday things like exercise. So this picture here is of a woman's treadmill. She captioned that dusty treadmill because it was something that used to be her happy place before she had Sjögren's, and she's not able to use it now, so she feels like it's just gathering dust. There was also some changes to food and diet and makeup as well, and the women were keen to kind of say, oh, these are kind of small things, you know, not being able to have a favourite fruit like apples, or not being able to eat sweets at Christmas, not being able to wear makeup, but they were actually quite big and impacted on their identity, and they weren't trivial. There was also a sense of loss in this about the person that they thought that they used to be and the life that they thought they would have. But many participants also spoke about acceptance, that they weren't necessarily ever going to be returning to a normal, but they were building something new, something slower, and creating a life that works with their body. And that acceptance didn't necessarily erase the hard parts and the challenges of living with Sjögren's, but it did show some of the strength and the creativity required for many when it comes to learning to live with this disease, and the unpredictability and learning to live with uncertainty. So what do all of these stories tell us? So it surfaced meaningful patient perspectives that can complement clinical understandings of Sjögren's. So there's lots of there is research done on, you know, more clinical understandings of Sjögren's, but this really kind of delves into what it's like to live and the experience of living with Sjögren's on a daily basis. It illustrates aspects of living with invisible illness and the impact of managing a systemic and whole body condition. It touches on every part of life. So balance and it touches on every part of life, like physical and mental health, work, relationships, finances, leisure. And it meant constantly balancing symptoms, appointments, energy, emotions, and expectations. And that is work. It also the findings also tell us that many of the hardest parts of the symptoms aren't necessarily the symptoms themselves, but it's poor awareness amongst healthcare professionals and the general public about Sjögren's disease, the lack of coordination in the health system, and the inherent uncertainty associated with the disease. Conversely, feeling heard and understood was really important to the people who took part in this. So I think that idea of uncertainty is important. We can't ever remove uncertainty in medicine, but we can communicate about it better. And this is where we would hope that this type of work will inform some of the other parts of the SYNERG-IE programme. So we're going to be looking at, as Michelle said earlier, the education and educational interventions, developing them for future healthcare professionals and current healthcare professionals. So we'll be able to inform those educational interventions through this work here. So I think I'll just leave it there. Owen is telling me my time is up, but I'll be happy to answer questions later on. Thank you.
Thank you very much, Nikki, and I'm very much playing bad cop for the day, so apologies. Just a brief reminder that there is a question box outside, and if anyone does have questions from Nikki's talk or for any of the other talks, feel free to leave a question inside, and we'll try and get to as many of them in the panel discussion later. I'd next like to introduce Prof. Frank Moriarty, who's an Associate Professor at the School of Pharmacy and Biomedical Sciences in RCSI. He's the RCSI lead for open research and is the overall is a lead for work package 1, which really is looking at medication utilization in Sjögren's, but is going to share today some data around hospitalizations in patients with autoimmune rheumatic diseases. So thank you, Frank.
Morning, everyone. Lovely to have the opportunity to speak to you this morning to share some results that we've been working on, and very much presenting this on behalf of Dr. Constanza Sakaran, who unfortunately isn't able to be here today. As Owen mentioned, we've done some work trying to understand what data do we have in Ireland on hospitalizations for autoimmune rheumatic diseases. So why did we look at this? Sjögren's disease obviously is a common autoimmune rheumatic disease, which can occur with other related diseases as well. Our current national level data on hospitalizations due to Sjögren's or other related diseases is fairly limited to date. We don't have good national estimates on this. So that's why we set out to look at what do we have in terms of national data on hospitalizations. We used a data source called the Hospital Inpatient Inquiry System, and this records for each hospitalization across public hospitals details of that hospitalization coded within each hospital. This is, I suppose, used for payments largely. So I suppose we understand that what gets recorded doesn't necessarily capture all aspects of a hospitalization, but we hope that the kind of key factors that led to that hospitalization are typically recorded. We looked at a range of autoimmune rheumatic diseases, rheumatoid arthritis, lupus, Sjögren's disease as a number of those. And then we looked at different groups within these hospitalizations. Those that were admitted as inpatients with a main diagnosis recorded on that hospitalization of an autoimmune rheumatic disease. We also looked where there were another main reason for that admission. And then we also looked at day cases, so where someone didn't get admitted to hospital overnight. And we'd some limited information available relating to those hospitalizations. And I suppose I'm not saying people because we don't actually know how many people these hospitalizations relate to. But we do have information around some demographics and the kind of type of care that was received. We looked at trends over time among inpatient admissions, and I suppose what we saw, the overall number was fairly low over a kind of 7-year period that we looked at. Nearly 4,000 inpatient admissions over this time with a primary diagnosis of one of these conditions that we looked at. Rheumatoid arthritis being the most common, as you can see up the top of that graph. And I suppose for Sjögren's disease that we saw relatively stable level at around kind of 30 admissions where this was the primary recorded diagnosis per year. But then in the more recent years we looked at that this had decreased quite a bit. In terms of the kind of patterns, as I said, yeah, fairly low overall numbers. When we looked at the kind of demographics behind this, overall, among all these conditions, about 70% of admissions were for females and about 45 among people aged 65 and over. When you looked specifically at Sjögren's, we saw a much higher proportion of females, 82% female, and about the same in terms of the proportion aged over and under 65 years of age. When we looked in slightly more detail and realized some of this information might be too small to read on the slide here, we were able to see how long did these inpatient admissions last. We saw that rheumatoid arthritis typically had the shortest duration of admission, longer durations of admission for conditions like Sjögren's at about 9.2 days on average, and then longer again admissions on average 15.7 days for myositis. We saw about similar kind of levels of emergency versus routine admissions across the different conditions. And when we looked at what the specialty that the admission happened under, we saw an interesting finding that actually for Sjögren's disease hospitalizations, about a quarter of these were admitted under neurology, so a much higher proportion of neurology admissions compared to the other conditions we looked at, and about a further quarter under rheumatology, and then ophthalmology making up the other kind of most common group there. We looked at how many other diagnoses were recorded on these admissions, and we saw about a quarter of Sjögren's admissions that didn't have any other diagnoses recorded. It's not to say that there weren't other conditions present, it's to say that they weren't recorded on that admission. When we looked at what the most common comorbidities across all of these conditions were, we saw that diabetes, hypertension, and glomerular disorder, a kind of kidney condition, were the most common when we looked across all of the admissions together. Just going to briefly present on the day case admissions, so for those cases where there wasn't an overnight stay in hospital. We saw a much higher number overall, about 45,000 day case attendances. Again, rheumatoid arthritis being the highest. And across the other connective tissue disorders, we're seeing, I suppose, an increasing trend over time, up to about kind of 300 admissions or day case admissions per year. We did also look at the kind of demographics in this group of admissions. Again, about 70% female, a lower proportion age 65 and over versus our inpatient admissions, so typically a younger cohort here. And again, when we looked at Sjögren's disease day case attendances, 91% being female, again, higher than for the other conditions, and about a third being age 65 and over. And similarly, looking at the, I suppose, further details of the admissions, we again see a higher day case admissions under neurology compared to the other autoimmune rheumatic diseases we looked at. And in terms of those other diagnoses recorded, much more of these cases where there was no other diagnoses, so about 3/4 where there's no other diagnosis recorded. So I suppose showing a maybe less, obviously acutely unwell group here, fewer comorbidities in these cases. Just to show two final graphics, we looked at, I suppose, the co-occurrence of the different autoimmune rheumatic diseases. And what you can see kind of is a common co-occurrence across the different conditions. The most commonly co-occurring pair being rheumatoid arthritis and Sjögren's disease. However, what we saw was a lot lower proportion of co-occurrence than what we know from other epidemiological sources. It suggests that we aren't seeing all of the conditions someone has being recorded on their admission, that about 80% of Sjögren's related admissions did not have another autoimmune rheumatic disease recorded as well. And furthermore, we looked at the kind of interrelationship between these and other non-autoimmune rheumatic diseases, and what we saw was conditions like hypertension, lung disease, urinary tract infections, pneumonia, commonly co-occurring with the autoimmune rheumatic diseases that we looked at, and we're planning some further analysis around this. So just to wrap up, the overall number of inpatient hospitalizations where an autoimmune rheumatic disease is recorded were low at about 550 per year within this data source. It emphasizes, I suppose, the importance of other care pathways for these diseases, which don't necessarily end up with an inpatient hospitalization. We saw differences across diseases. Rheumatoid arthritis has had a high frequency of admissions, and particularly with Sjögren's, a unique pattern with a high proportion of neurology-related admissions. Overall, there was typically stability in admissions over time, some decline in rheumatoid arthritis, modest increases in lupus and sclerosis-related admissions, possibly reflecting clinical management that actually were avoiding people having to be admitted to hospital and maybe being able to provide better care and treatment through outpatient settings. And I said that kind of network analysis that I showed at the end shows a dense pattern that there's lots of interconnections between these rheumatic conditions and other conditions that patients are admitted with. And we are further planning some analysis to look at how this differs across counties. So is there a geographical difference across the country? And also to look at any recorded procedures that were conducted during those hospital stays. So thanks very much for your attention, and yeah, very much welcome any questions that anyone might have later on. Thanks very much.
Thank you very much, Frank. So our next speaker this morning is Dr. Natasha Jordan. So Natasha is a colleague and consultant rheumatologist in St. James's Hospital and a clinical senior lecturer in Trinity. She has a long-standing interest in autoimmune rheumatic diseases, having undertaken a PhD on the genetics of lupus nephritis during her time in London. Subsequent to her PhD, she took up a role as a consultant in Addenbrooke's in Cambridge, where she did a broad range of clinical and research interests, particularly focused around clinical trials in rheumatology, with subspecialty expertise in Sjögren's, lupus and antiphospholipid syndrome. So for this morning, we tasked Natasha with the job of maybe beginning to reflect on the initial findings of SYNERG-IE to date, and we're very much looking forward to hearing her thoughts on this. Thank you very much. Welcome, Natasha.
Up there? Okay. All right. So my talk is a little bit different than that it says on the agenda and the slide. I'm going to reflect from a clinical point of view on the findings that I presented in the first two talks, because that's really what it's all about in the long run. So first of all, just Frank's talk, there's some, I thought, very interesting information there that is relevant to patients and doctors who look after patients with Sjögren's disease. So the first thing I want to talk about is the inpatient admissions, and I thought this was quite interesting. So as Frank said, the highest number there is rheumatoid arthritis, because rheumatoid is a much more common condition than the other autoimmune rheumatic diseases like Sjögren's and lupus and myositis. It's interesting that the rheumatoid arthritis admissions seem to be tailing downwards over the period of the study. I don't think there are huge changes for the other conditions. I think this is interesting and tells us maybe where we want to be with Sjögren's in 20 years' time. So the rheumatoid patients, I have nothing against them. I'm just a bit jealous. But they have now 25 years benefit of biologic therapies, so things like anti-TNF therapies. It was around then when I started to train in rheumatology around the year 2000, 2001, was when those drugs came out, and they revolutionized rheumatoid arthritis. And I think perhaps this trend in reduced hospital admissions for the rheumatoid patients, the admissions were shorter and they had less comorbidities, is possibly because they have these treatments now for over 2 decades. I would say lupus is probably 10 years behind that, and Sjögren's, unfortunately, is further behind still, but I would hope that would change. That's what I think I'm seeing here, and I hope we can change that. The comorbidities I thought were very interesting. So the top 2 comorbidities that were seen with patients were diabetes and hypertension, so high blood pressure. And that's quite worrying, and it's something, you know, we knew this, that there's a higher rate of these across the autoimmune rheumatic diseases. And I think this is really important, and I'm going to come back to it. Because while we want to treat Sjögren's disease, we can't forget that we have to really control all those comorbidities and how important they are for patients' health. So I think that's come out quite strongly in the study, and I think that's really very, very essential. Now, the day case admissions, I thought this was quite interesting, and you can see that, again, the rheumatoid patient group is the most numerous. and there's kind of a drop in the number of day cases. And again, I think is because the rheumatoid group have this now wide variety of biologic treatments that we don't have for lupus and Sjögren's and the other conditions. And while those treatments initially were intravenous, after a few years, that very much changed. So most of those are subcutaneous treatments now. So that means that the patient can do their own treatment injections at home and not have to come to the hospital to the day ward, which is obviously much more convenient for their quality of life, and they're really in charge of it themselves. Now, on the bottom of the graph, you can see that for Sjögren's disease, lupus, and myositis, and systemic sclerosis, there's an increase in day ward attendances. And I see that as a good thing. And I think that is most likely because we are beginning to use biologics, such as rituximab and belimumab in lupus, and those are intravenous, so the patient does have to come to the hospital. Yes, ideally, it would be nice if they could have treatment at home, but what I'm reading from this is at least we do have those treatments now, and they're beginning to come into the world of Sjögren's and those other autoimmune diseases. So I would see that as encouraging that those patients are coming to those day case appointments. But unfortunately, am I one step out of kilter on that? No? No? Okay. Unfortunately, the management of these autoimmune rheumatic diseases is still far from optimal, which I didn't need to tell you. I'm sure you all want to tell me that. Early diagnosis, which I'm going to focus on, is a big challenge. And we saw that in Nikki's talk, the frustration of not being able to get a diagnosis. I want to emphasize about steroids. I prescribe steroids. I prescribe steroids for people in this audience, so I use them, but we do rely heavily on them, and that's something we do need new therapies so that we can move away from their reliance on steroids. The reason I wanted to emphasize the diabetes and the hypertension, the high blood pressure, is because we know that patients across all autoimmune rheumatic diseases are more likely to get earlier heart disease and atherosclerosis, and that this can be a major cause of morbidity and mortality. Now, steroids don't help that. So I think that's quite important that those comorbidities were emphasised in Frank's talk. Now, there's a lot more long-term data from lupus patients, which is an area that I'm very interested in, and lupus is very closely linked to Sjögren's, so if you allow me the liberty to send some messages via the lupus patients. So this was a study comparing lupus to rheumatoid. Again, sorry for picking on the rheumatoid patients. So I'll break this down. So we have two patient groups, lupus and rheumatoid arthritis, and we have two time periods. We have from the late 1990s to 2006, and then 2006 to, I think it was 2014. And they can see that from the first time point to the second time point, that rheumatoid patients had improved mortality, whereas the lupus patients, it didn't really improve all that much over time. Again, this is showing that the rheumatoid patients are benefiting from the biologics that have come out and newer treatments, whereas lupus patients haven't had newer treatments or didn't really at that time point. So I think that's a reflection of what's going on there. So again, emphasizing the need for new treatments for lupus and certainly also for Sjögren's. Now, going to Nikki's talk, there's an awful lot to unpack there, and this is the bit that really, I thought really stood out to me, the pre-diagnosis. If I could just get a showing of hands, how many people here really struggled to get their initial diagnosis of Sjögren's? So I was going to say half the room, that's the whole room, So this is clearly a huge, huge, huge issue. Then how many people, when you got your diagnosis, felt you got your diagnosis, but it was very much parked at dry eyes, dry mouth, move on, and there was that frustration. So again, if you get an idea, and again, all the hands are up. Okay, all right. So I want to talk a little bit about getting a diagnosis. So despite Sjögren's disease being a relatively common condition, there is limited awareness about diagnosing it, the nature of the disease beyond dry eyes and mouth, and this is among healthcare professionals and the general public. And this, as you don't need me to tell you, but this can lead to frustration, delays in diagnosis, ineffective or the wrong treatments, and insufficient support for the patient going through this journey. So diagnosing Sjögren's can be tricky. A lot of the symptoms can mimic other things that can be a distraction, can mimic other autoimmune diseases, menopause, dry mouth, for example, can be a side effect of a lot of drugs. So there can be a lot of noise that can delay the diagnosis. Now, unfortunately, and there's a big stumbling block, there's no single test to diagnose Sjögren's. The tests that we do use can be eye tests, which I'll leave to my colleague, the next speaker. They can be tests to do with saliva, but what you'll encounter going to your GP, first of all, will be the blood tests, so I'm going to talk about those. So again, a showing of hands, people who this was the first stumbling block, just getting the blood test done, if you could get an idea where this was a problem for people. So again, maybe about a third of the room. So you'll have most likely heard of anti-Ro and anti-La, the two main antibodies for in Sjögren's disease. So that's all well and good that these antibodies are there and they're helpful, but when they're not there, they're not helpful. It can lead to a lot of confusion. So these antibodies are present in about 60 to 70% of patients with Sjögren's disease, but that leaves about a third of patients that are in a little bit of limbo if these tests aren't clarifying the situation. So what I've done here is give a list of some other blood tests that you might want to encourage your doctor to do or that can help things along. And if I, for example, was receiving a referral query Sjögren's disease in a patient, these would be very helpful and might prompt me to see a patient more quickly when I had more information. So ESR is a general inflammation blood test. It's not specific to Sjögren's, but it should be readily available in GP practice and hospitals. Now, I have noticed lately, I don't know if it seems to be not available with some GPs in North Dublin of late since this year. I don't know why, but otherwise it is a really useful test. The next test is called complement, C3 and C4. Not a very commonly done blood test, but it is available to GPs. So ESR, if you're inflamed, will rise. Complement, if you're inflamed, the opposite happens. Your complement is consumed by the immune system and the levels drop. So a low C3 or C4, very helpful to assess Sjögren's. The next blood test, no one ever thinks to do this, as far as I can see, for referrals for Sjögren's, but it's rheumatoid factor. A very old blood test, was the original test for rheumatoid arthritis. We now have newer antibodies for rheumatoid. But rheumatoid factor is present in about 50% of Sjögren's patients, so it's very useful to build a kind of a profile of what the immune system looks like. Again, readily available, any doctor can order it. Immunoglobulins, again, widely available. One in particular called IgG, it's a kind of protective antibody. It can be elevated in Sjögren's. Again, it's useful to know. It helps me build up a picture of that patient's immune system. And the last blood test is TFTs, thyroid function. So about a third of patients with Sjögren's disease will have thyroid disease, and that is a big cause of fatigue. So it would be really a mistake to not check thyroid function. So if you want to take note of those bloods and maybe encourage people to check them, that would be useful. Now, Nikki's other slide was, that I found very interesting, was living with invisible disease. And I try to understand how frustrating that is. Again, I'm going to look at a lupus study here as an example. This was an enormous study of over 4,000 patients all across Europe, looking at the burden of lupus, which is very similar, identical to the burden of Sjögren's. And what they did was they asked patients what was their most frequent and most difficult to deal with symptom. And the top ones you'll all recognize. So fatigue was right up there as the over 80% saying it was the most frequent and burdensome symptom. And then after that you had joint pain, and dry eyes and dry mouth actually featured very strongly. When you look at the symptoms that were least troublesome for the patients, they were things that probably doctors are more interested in. So there was things like osteoporosis, kidney disease, stroke. So we had a kind of a mismatch of what maybe doctors want to ask you about and what patients are actually most bothered by. And that's definitely food for thought. Now, when you've gotten your diagnosis, a lot of people, and I mean doctors, will assume this is just dry eyes and dry mouth and that's it. But there's an awful lot in Sjögren's beyond sicca, the dryness symptoms. There is systemic disease that can, from this graphic, you can see affect any organs throughout the body. Most often the lungs, the joints, the skin, the peripheral nerves. And we just don't have enough data about this, and this is really, really important. And I think we underestimate that how much of the body can be affected, not just dry eyes and dry mouth. Now, I just want to show this as, again, it's an analogy to lupus. From that same study of the more than 4,000 patients with lupus across Europe, it looked at what medications they're taking. And I thought this was really compelling stuff. So about over half of patients were on some amount of steroid, which is a major issue, as I've said before. And what is even more worrying is about 10% of lupus patients were on a biologic therapy, and I suspect it's less than that in Ireland, and I suspect it's much, much, much less than that for Sjögren's disease in Ireland. Whereas if you were to look at the rheumatoid patients, I'd say more than 50% are on a biologic therapy. So I think this is we have some distance to go to change that. So I want to end up with a few positive slides because the biologics are coming for Sjögren's. So they typically, like all biologic therapies, have very unpronounceable names, so I'll do my best. So one that is quite hopeful is called ianalumab. It is in phase 3 studies. So how medicines get through trials is they go through phase 1, phase 2. Unfortunately, a lot of medications fall out at that point. So to get to phase 3 is very encouraging. It means something's working and going well. So ianalumab targets B cells. They're the cells in the immune system that make autoantibodies, that drive autoimmune diseases. There's another one called iscalimab that targets a thing called CD40, another important part of the immune system that is known to be involved in Sjögren's disease. The next one I'm not even going to try and pronounce, but it also targets CD40. And the one that probably most people are excited about is called nipocalimab, and that targets a thing called FC receptors. And I'm going to show one slide on that. So on the left, you have a score that we do in clinical trials in Sjögren's called the SYNERG-IE, and it's a combination score of all the different clinical issues that a patient can have. The blue line is the 15 milligram per kilogram. Is it there now? Yeah. They're mismatched on the screen, which is throwing me off. So the blue line at the bottom is a 15 milligram dose of this particular drug. You can clearly see the difference between the peach boxes and the blue boxes, that this drug has worked for the SYNERG-IE. Then in the second slide over on the right is a thing called the ESPRI, which is the patient-reported score, so how the patients feel they're feeling and how their symptoms are. And again, at the bottom, so the lower the score, the less of a problem. So again, you can clearly see that the blue boxes are on the lowest, whereas the peach boxes are up high, and the grey is placebo. So again, this drug, Nipo, was shown to work from the patient's point of view, and this is very, very encouraging. So I think there is hope that we will have biologics, hopefully in the next few years for Sjögren's, and that in time we will catch up on those people with rheumatoid and other conditions. What is the future for Sjögren's? Well, from both talks earlier, we can see there are several unmet needs for patients with Sjögren's disease. We need to aim for earlier diagnosis for our patients and better remission. A question we can't answer yet is what is the most appropriate subset of patients for a particular therapy? I think we're at least 10 years away from that. We need to use less steroids. And I think if and when these treatments do become available, we'll have new battles to fight, like cost and accessibility. But that'll be a fight for another day. Thank you.
Thank you, Natasha. It's always good to hear the hopeful future laid out for us. My name is Mags. I'm a retired teacher and an independent researcher, but I'm here today as patient representative, and just want to press pause for a moment and wave hello to the people online at home and say, please put your questions into the chat. Today is for you. This time last year I was at the at-home version of today, and it really, really helped me in my journey. And part of that is that it's about 18 months since I had a diagnosis, and around the time of my diagnosis, and this is why I want to give a shout out to the first table up here, to the 3 women sitting closest to us. What I got along with my diagnosis was information that there was a group in Ireland. So Gráinne's not here today, but Eileen is here, Monica's here, Deirdre's here. I'd like a little show of appreciation for the for the people who started the patient participation part of what we're here today for. So thank you all for that. The question box is still out there after Emily speaks. Please put your questions in. That was what the focus of the second part of the morning is going to be about. So it is my joy and pleasure to introduce Dr. Emily Greenan, and in our world, in our disease, doctors are very important. She's a doctor of ophthalmology, but also a doctor of Sjögren's disease. Her research was in Sjögren's disease. And if you're interested in seeing her in action as she was a research student, Google her and find the Bright Club presentation she did a few years ago. Very, very good. So, Dr. Emily Greenan, come and enlighten us, please. Thank you.
Thank you so much. So thank you for that lovely introduction. I feel like I've been put on quite a pedestal there, so I hope I live up to expectations. So as I was introduced, I'm Dr. Emily Greenan. I'm an ophthalmologist, so I'm working in the eye and ear at the moment. But as Mag said, I did a PhD which through RCSI, which focused on allo and autoimmune-related dry eye disease. So Sjögren's was a huge part of that. And possibly there are people in the room who participated in the studies that we did and really shone some light on the condition. So what I was going to look at today is I was trying to pitch this at you, the audience, and your experiences, but also to your friends, your family, try to explain what's happening on the eye surface, but also to other allied healthcare professionals, that dry eye is multifaceted, and it's not just whittled down to that term. So I was trying to explain what happens on the eye surface, where maybe ophthalmologists and other clinicians can come in and help you get that earlier diagnosis. The referral pathways aren't there at the moment, but things that we can look for, and the treatment approaches that are there, and some takeaways. Just very quickly on the eye surface. So Sjögren's is an autoimmune condition, as you all know, but those autoantibodies are attacking that lacrimal gland. It lives up here, up at the top of your eye, just underneath the bony aspect, and it's what's producing all of your tears. So actually, you don't have to have a huge amount of fibrosis or sort of degradation off that gland for it to no longer produce tears, because the ducts close over. When that happens, that reduces the amount of tears that are produced, and that leads to what we call aqueous deficient dry eye disease. So while we might talk a lot about dry eye disease, the entire tear film becomes affected in Sjögren's, and I think that's a really important thing to highlight, because lots of clinicians, and sometimes maybe ophthalmologists too, we think lubricants, but there are other aspects to it too. So we know on the eye surface you have tears, but you have an oil-producing gland as well on your eyelids. And over time and with age, these can drop out and become blocked. But in a Sjögren's cohort, this happens to a much higher degree and much sooner. And it's a bit like having water, a glass of water and oil on top. There's no longer that oily layer protecting for evaporation, so your eye surface becomes much more exposed, much quicker between your blinks. So this leads to what people often call a vicious cycle, or I think just a spiral. One thing's just leading into another, and bang, 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 and you're in this cycle of symptoms. So we start up the top with aqueous deficiency or tear deficiency, your gland dysfunction, your tears evaporate. Then you start getting damage on the surface of the eye. All those inflammatory markers increase, so it almost becomes a hyperosmolar, because there's more friction on the eye surface, and it leads to damage. So why does that matter? It's because Sjögren's is often mixed. It's both aqueous deficient and evaporative, so really we should be tackling these two elements along with some localized anti-inflammatory treatments to better manage the symptoms and to improve the eye surface. It increases the symptom severity and then affects our treatment options. In terms of the patient experience, I don't want to speak on behalf of the room. I'm really not trying to do that, but it was for your family members or for other allied healthcare professionals to understand that the term dry eye is so much more. And these are some of the things that have been said to me and that have come through some of the questionnaires, that it's gritty eyes, it burns and it stings. It affects, it's not just a sensation of dry eye, but it really affects vision, and this vision fluctuates as well. It leads to light sensitivity. It's very difficult in terms of eye fatigue, especially with screen use. And these symptoms are worse in wind, in air conditioning, dry air, or cold weather, and especially people who are working in communal offices where there's so much air conditioning. In terms of clinicians, and maybe this is to the physicians who aren't ophthalmologists, what are we seeing on the slit lamp? What are we seeing on the eye surface? What has been written in letters? So things that we look at and measure clinically are, we look at that tear film height. We talk a lot about how much tear and try to quantify it. We look at the tear breakup time, and if you see that second photo, what I was trying to explain with that oily tear film and why it's important, see the top part of it is covered, and then there's like a break in that fluid layer. So that's that break happening in your very little amount of tear film that's left. And that part of your eye becomes exposed. It's becoming exposed more frequently because it's less covered. It's kind of like having, I'm trying to explain it to people who don't have Sjögren's, who don't have a dry eye. I'm like, it's kind of like cotton mouth, you know, when you fall asleep with your mouth open, it's very dry. It leads to staining on the eye surface. Everything in green on that top picture is a part of the eye surface that no longer has its nice cellular covering and isn't protected anymore as those cells become devitalized. And it can lead to this hyperviscous tear film that can then just perpetuate damage. So this is what we're looking at and we're trying to measure. I will come back to questionnaires and experience in a second. But why do these things matter to eye care specialists, and when you're speaking to your ophthalmologist, and for people who maybe don't have a diagnosis yet? You know, it's known throughout the literature, and definitely in my experience, that the dry eye symptoms, this presentation, can be the first early sign of Sjögren's. It can be the first telltale sign that it is perhaps a condition, and that's why it's important for ophthalmologists or other eye care members of the eye care team to have it at the forefront of your mind when you're meeting a patient who's presenting with these signs and symptoms. And as I was looking through, it's thought that 10% of patients with dry eye have Sjögren's, but 2/3 remain undiagnosed for years. And I think that very much aligns with what we had our show of hands in the last presentation. And when the diagnosis is delayed, you know, it unnecessarily impacts on quality of life day to day. Again, when should we be thinking about Sjögren's? Natasha very nicely outlined, the different tests, the delay in diagnosis, the criteria. There's no single test, and definitely ophthalmologists come into that. The diagnostic criteria do contain clinical signs, but before that, when should we be thinking of it? And looking for those signs and measuring the tear production and the staining. And I think it's persistent refractory dry eye disease. It's going on for more than 3 months that isn't responding to dry eye treatments. Lots of people say they have dry eye. Lots of people have dry eye, increases with age. But Sjögren's, it's persistent and it's refractory. Your reliance on lubricants. I'm sure there are many people in the audience going, lubricants 3 times a day, I wish. I'm sure people, but it was in the previous diagnostic criteria, so that's what I've included. And then it's about asking more. So, I do come across patients who come through the emergency departments in eye clinics who will come in with very bad dry eye, and it's about asking more questions and not just looking at the eyes. And the referral pathway, I'm sure like many of you have experienced, there isn't one. How do we get you your diagnosis? How do we funnel you through to our multidisciplinary care? And I think it's about raising awareness and trying to improve that. So I unfortunately don't have an answer for that, but it's hopefully in having talks like this, it's hopefully improving awareness about with other healthcare physicians. Symptoms and questionnaires in dry eye disease with Sjögren's. In Sjögren's, symptoms can be disproportionately severe. So in the nice pictures that I showed a second ago with all the green and the blue light ups, you might not have all of those signs, but you're still going to your ophthalmologist going, my eyes still feel really bad. I'm not feeling this improvement that you're telling me I'm having. And the converse of that is sometimes they can look really bad under the microscope and, the symptoms mightn't be as bad. And that's what we sometimes call as pain without stain. And there is a disproportionate or a mismatch between, because there can be nerve damage, so they can be hypersensitive, or actually with time it can be downgraded. And we had shown this in a paper that was produced through RCSI, and it was concluded in that that clinical signs do not always align with symptoms, and therefore clinicians should be cognizant and adjust treatment in accordance with patient-reported perceptions and not just clinical signs. Okay. Questionnaires that I think are probably quite good. Some people might be aware of them. The commonly used ones are the OSD, the SANDI, and the SPEED. The OSD is used a lot in research, and I quite like it because it talks about symptoms, but it talks about environment and it talks about functionality. So I think it's encapsulating the impact throughout your day of dry eye, and it puts a number on that, and it classifies it in terms of mild, moderate, and severe. And I think it allows that quantification of kind of someone saying, my vision is fluctuant, it's sore, it stings. It puts a number on that, and it's a benchmark to allow us to monitor and change treatment towards. And also might help identify patients, because we know people with Sjögren's score very severely on it when compared to other forms of dry eye. Before I finish, I was going to go through some treatment approaches and some tips and tricks. I wish we had new treatments coming down the line like we do in rheumatology, but maybe with time, it will improve the clinical presentation of our patients in eye clinics who have Sjögren's. But we're perhaps a little behind our rheumatology colleagues. In terms of environmental, I have a picture of the washing line here. I think anything that dries your clothes really well dries your eyes. So anything that's, low, the humidity, avoiding fans, screen time and taking visual breaks, protective eye care. I also have this little bit at the bottom about lid hygiene compresses and oils. It's because of that oil factor that I talked about at the start. So those few glands that are still working, it's trying to encourage them to produce their lipids or their oils onto the eyelid surface. Omega oils, some people might take them, the jury's out as to whether or not they are of benefit. Those Cochrane reviews, and there was a DREAM study, but they can be helpful. This is a bit of a practical point. The cornerstone of treatment is artificial tears and lubricants. I often, when I write it, it's not about having a bottle a month, it's having a bottle in every place, in every pocket, in every car, everywhere, in every handbag. This is things that I take into account, and I just wanted to highlight when I'm prescribing for patients with Sjögren's. There are lubricant drops to use during the day. You can see better through them practically. It's just easier. Gels can be useful, but if you're having dry eye symptoms that are waking you up at night or really bad in the morning, ointments are great, but they're not as functional to use during the day because they're paraffin-based. And overall, they're hopefully reducing the friction and damage on the eye surface. Things to consider, and this is something I wanted to highlight to my eye care colleagues, was price and administration. Lubricants are really expensive. They're available over the counter, but lots of them are available on the drug payment scheme. And if they're €20 a bottle and you're going through bottles and bottles and bottles of them, put them on a prescription. This is publicly available, but you can look at the HSE reimbursable items and see what lubricants are on that. So there's lots of, no links to pharma, but there's lots of them, like some the High-Low Forte and the High-Low Care, but the High-Low Intense isn't, so it's, or the Thelos is, but the Thelo Night isn't, Celluvisc is there, Artelac is there. So there's lots of different ones, and I never like telling, if a patient with Sjögren's comes into me and goes, I use this drop, this is the one that works, absolutely fine. That is the one that works for you. They all use slightly different bases. So it's about finding what works for you. So try them. Absolutely try them. So the cost is important, so have a look. And then the administrative, we talked about Sjögren's patients having a lot of comorbid conditions, so the bottles are important. So the High-Low has a press button, some of them have a squeezy button, some of them are single dose units, and it's just find what works as well. Everything should be preservative free. Steroids, topical. I haven't found that oral steroids make a difference. They hopefully get you out of a cycle of bad inflammation, so we kind of pulse and go with them. And they're generally tapered, but they can cause pressure problems and bring on cataracts sooner. Some people might be on Icurvis, or what is a cyclosporin, which is sold as Icurvis in this country. It's a steroid-sparing agent. It stings a lot. Anyone who is on it, often steroids are used at the same time and used to bridge, but it's a slow burner. Other things that are used are punctal occlusion, so that can be permanent with cautery or with plugs. So people get a little bit confused about this, but it can be quite helpful. You have a drainage system that goes into your nose. That's when you cry, you get a really snotty nose, so it's trying to block off that system. And there are a few other things. So serum eye drops work very well. They've got growth factors and help with healing. Pilocarpine I've never prescribed for an eye patient. I think the jury, hasn't really been shown to be helpful in terms of eyes, but definitely helps with maybe more oral symptoms. And then there's other things, maybe like scleral lenses. And there are some studies going on with stem cell injections into the lacrimal glands. I know those are in early stages, but they've been in animal models. So maybe that's something down the line that hofully would hopefully improve and undo that damage to the lacrimal gland. So my takeaways are Sjögren's is multifactorial on the eye surface, and the symptoms don't always match what our patients are experiencing, and it's so important to listen to the patient voice. if we can improve early recognition and point patients in the direction of a diagnosis, there are multiple treatment options available, and treatment can change as well as disease waxes and wanes, and we need to add in anti-inflammatory treatments. Thank you.
So welcome back, everybody. I hope you enjoyed your break. So for the next session, we're really just going to try have an interactive question and answer session with our speakers from this morning, asking the panel. We have lots of interest, some questions online that Frank may address for us towards the, at the back, as well as some questions that have come in throughout the course of the morning. As well as questions that came in actually before the session. So just I think to throw things open, we have a couple of questions around eye care, and I suppose really for Emily around regarding serum drops. Does it make a difference to a patient who uses autologous or allogenic drops? And again around if oral steroids dosage being changed, does it have a negative impact on eye symptoms? So we might ask Emily to comment a little bit on some of those for us.
Yeah, so first of all, a question about serum drops. So there's two types. People may or may not have heard of them. There's autologous or allogenic. Autologous or they're yours. It's your blood serum, and allogenic is from another person's blood donation. So really, it's never really been shown that there is a difference between using yours or someone else's serum. If you have high inflammatory markers, then it's better to have allogenic. But what it really comes down to, I think certainly in Ireland, is practicalities. So the serum eye drops at the moment come from Galway. So if you're near Galway, then great, you can give your own donation, but otherwise it's impractical because that's where they're prepared monthly and prepared sterilely. So often it comes down to practicalities. So I think that's really more so where it is. And I don't think, unless you have a reason to have high inflammatory markers, there hasn't been a difference. In terms of, someone had asked if oral steroids, reducing dose, does that have a negative impact on eye symptoms? Not that I've experienced, but certainly I think if you're having an increase in your eye symptoms, again, that experience is important and something important to raise with your ophthalmologist. It mightn't necessarily be linked to the steroids, but maybe to your environment, maybe you're just having a flare of the eyes, the inflammation is getting ahead of everything else, never mind the aqueous or your decreased tear production. So I think, that experience itself is important to maybe tailor the treatment, but directly being linked to the steroids, I would say unlikely, because often the lacrimal gland is damaged by the time you're experiencing dry eyes, and that's not going to undo that.
Thanks very much, Emily. Are there any questions from the floor at this point that anyone would like to ask? No. So I might just move on to some of the other questions that we have here. I suppose there's a number of questions are centred around kind of the overlap between lupus and Sjögren's and kind of how you can differentiate between the two. Kind of. So Natasha, would you mind commenting a little bit more on that?
Okay, so I see lupus and Sjögren's as sisters or very close cousins. There are symptoms that overlap between each condition, and there are antibodies that overlap. So the anti-Rho antibody that you see, in, as I mentioned there earlier, it's 60 to 70% of Sjögren's disease patients. We see anti-Rho in about 30% of lupus patients. We don't see anti-La very often in lupus. So there are similarities with the antibodies, but differences. I know this, it is confusing, and it confuses a lot of doctors as well. There are certain antibodies that we find in lupus that we wouldn't in Sjögren's disease, so like anti-double-stranded DNA and another called anti-Smith would be examples. As I said, there are symptoms that are similar and there are symptoms that are different. So to give an example, kidney disease is generally more severe in lupus, and if you do a kidney biopsy, you'll see a particular type of inflammation. Sjögren's disease can have kidney involvement, but less often and less severe. And if you did a biopsy, it looks totally different. So they are linked, but there are very distinct differences as well. And the same goes for treatment. There are some treatments we use for both conditions, but then other treatments that we would only exclusively use in lupus at this point. So some people have a diagnosis of both. I think theoretically that's probably not correct. You might have an overlap between the two, but not two distinct illnesses really, theoretically. I never reverse the diagnosis if a patient has symptoms of both. I don't see any point or that it's helpful to change that. The reason they're so linked in blood tests and symptoms is they come from a common origin, and partly that's genetics. So when they've done very big genetic studies in lupus and Sjögren's and other autoimmune diseases, we see that there are some genes in the immune system that have gone awry in both conditions. So that is really, I think, the origin of why they're so similar. But there are probably differences we don't understand yet of why they're not the same thing. So a long answer, but I know several people ask the question, and I'm always being asked this. People are very interested.
Yeah. And building on that a little bit, Natasha, there are similar questions around the role of antibodies and whether patients with the antibody have a worse outcome of the disease rather than someone without antibodies, with them without.
So I suppose what you mean by worse. So there is worse in terms of your quality of life and symptom burden, and I'm not sure antibody is the cause for that. But patients who are what we call seropositive, who have the antibodies in Sjögren's disease, are more likely to get more of the organ involvement in the systemic disease, like the kidneys that I just talked about. So I suppose we would be monitoring in a slightly different, more intensive way in patients that are seropositive, looking for inflammation in organs that we would need to pick up sooner rather than later.
Yeah. Excellent, thank you very much. And there's another question, and I might kind of coincide this with actually asking Frank to maybe open the floor to some of the online questions, because this is probably directed towards himself. In the studies of the HYPE data, kind of what conditions or symptoms did patients have that were classified as emergencies when they were presenting for admission, or is it possible to tell?
Yes, it is working.
He's behind you.
It isn't fully possible to understand, I suppose, what symptoms are present. Often it is just recorded as the kind of reason for diagnosis, and we can't really drill down into more detailed information about that. We are hoping to access some primary care data later in the project, where we will be able to, I suppose, interrogate healthcare use and hospitalisation data in more detail. So, yeah, watch this space. We should have more findings soon.
Great. Thanks very much, Frank. And I might actually, as you have the microphone, leave the floor open to you for now, if they're to ask the panel if they have any questions coming through online that need to be addressed.
Yeah, so there was a question around whether clinical trials could be much more useful for patients if better Sjögren's patient phenotyping or stratification was undertaken. So, a comment in relation, or a question in relation to some failed drug trials where there does seem to be some responders, but that the trial overall is still a failure. And I think Dr. Jordan mentioned during her talk about kind of stratifying patients more effectively and knowing which treatments might work best for which patients. So I don't know, is there any further progress we can see happening in that space?
That's a great question. So I think, back to the rheumatoid people, but I think because that disease is more homogeneous, or all patients are very, very similar to each other, it's much easier to do trials and see what the outcomes of the trials are. When you have diseases like lupus and Sjögren's and patients are not all identical, it is much more difficult. So there were studies, for example, like rituximab, a study called the TRACTIS study that some of you might be aware of, that the outcomes weren't as good as we hoped they would be. And part of that could be that all the patients were put in as one entity, and maybe we should be looking at different subsets of patients. So there was some research published only in the last year or so. I can't remember the author, I'm afraid, but it is kind of subdividing patients with Sjögren's disease into, I think it was 3 different subsets, whether people mainly had glandular, high inflammatory state. So it is looking at that. And I think that's really good, because then future trials will look at different subsets of patients, and I think you're much more likely to see that drugs will be successful in those trials, and then we'll have a better idea of what drug might be for what patient. So instead of lumping everyone in together, it will be looking at the discrete differences, and I think that's a much better way of doing it, and I think it is coming.
Yeah. Thank you very much, Natasha. I think there's a question at the front here. Sorry, if someone has a microphone. No, it's on its way. And just whilst we're waiting, just to build on Natasha's point, I think just to highlight even though some of these studies are failed trials and they don't reach their primary outcome, the lessons that you learn in terms of designing future studies are really, really excellent in terms of kind of being able to help patients down the line. And I think although there may not be a successful treatment outcome, I think the lessons that are learned will allow patients probably to clinicians to move the care forward in terms of trial design that will better identify patients in the future as well. Sorry, yourself.
Hi. I'm just wondering, is there such a thing as mild, medium and severe Sjögren's? In other words, could a person teeter on the edge for years and never get to the point where they're damaging their kidneys or their lungs and just have more minor or medium severe symptoms?
Yeah, absolutely. And I think that what I was just saying there about that paper that was published in the last year or so is doing that. It's looking at patients in these different groups. And I think that's really important. The most experience I have this is in the world of lupus, where again you have kind of mild, mediums and severe patients. And I think that's really important, because if you're new to Sjögren's and you Google Sjögren's or lupus, you'll automatically hone in on the worst symptoms and presume that's what's in store for you, and that's not necessarily the case. So I think the sooner we start to kind of subdivide the different categories of Sjögren's, I think that will be really helpful. Yeah.
Great, thank you very much, Natasha. Are there any other questions? If not, I've got one that that's interesting. Someone's inquiring as to where the disease name came from. I felt that like there may be someone on the floor who is happy to answer this question. Exactly.
So it was I'm Swedish. It's a doctor in Sweden who put 1 and 1 and 2 and 3 together and understood what really was happening, because it mainly affected women 40, 50 plus, and they came to him and was suffering from this, that, and everything, and he was able to put it together. It's called Sjögrens. That's the way I say it, but I speak in a dialect. So, but everybody here is pronouncing it very, very well. And the Sjögren's day, 23rd of July, he was born on the 23rd of July, hence that day.
And Mags is pointing out, I think there's another question down the back.
Hi, I just wanted to ask the panel, I have Sjögren's, and a lot of people I talk to who have, one of the major things is anxiety about and you're now calling it a disease as opposed to a syndrome. And Google is so bad, and even today when I came in, I got anxious because I thought, do I want to, it's when you're a patient and you don't have a medical background, sometimes there's too much information because we don't understand, and then we go off and we Google it and it makes it worse. So it's good for me now because I've got to a stage where I trust the people that I'm going to see, the rheumatologist, but when you're just with the GP and things like that, it gets very difficult. The dentist I find really good as well, and the ophthalmologist. So how do we stop Googling and worrying about our kidneys and our heart and how do we manage it all?
It's a really great question, and as someone who suffers from Sjögren's disease, and I think when you first get your diagnosis, nobody has heard of it. And the first thing we all do is go on to Google and have a look and see what's before us. And I suppose that's one of the reasons that we set up Sjögren's Ireland, was as a source of information for people. So, you know, to provide links to trusted sources of information, whether that's international literature, whether that's other Sjögren's bodies around the world, and to provide that sense of community as well, where you can ask a question in the WhatsApp group in a safe space. I think, yes, the temptation is always to Google and you know, our minds go to the worst place, but I think that, you know, reaching out to people who are in a similar situation can sometimes alleviate that anxiety when you understand that there's different severities of Sjögren's, and, you know, many people, I think, go on to live perfectly healthy and good lives.
Thank you. I think that's a really good question as well, and it definitely came out of the photo voice study, just that anxiety and worry about the future, even at, like, not just at initial diagnosis, but even after, you know, people had been diagnosed years. What really came out from that was, I think, the uncertainty around kind of what the future held was a clear worry, but just to add on, like, the peer support was absolutely critical, but also healthcare professionals who were able to communicate that uncertainty and the unknowns in a very clear way as well. So, but actually a comforting way of, like, these are the things that we can do to manage it. We might not know exactly what's going to happen in the future, but these are the things that are, so I think just the clarity even around the unknown from healthcare professionals did seem to ease people's worries about what was going to happen. So I think peer support and kind of just really good communication from healthcare professionals was really important for our participants.
Thank you, Nikki. I think we have another question. Sorry.
Yeah. Hi, I'm just wondering if you've done any studies on, or there have been, on Sjögren's over a lifespan, you know, how it's progressed for a person. I've had it since I was 35, and there's been peaks and troughs. And I suppose as I'm getting a bit older now, I'm just wondering, will it get better or will it get worse? That's kind of a worry for me.
That's a really good question, and I'm not aware of actually any literature that's doing that in the Sjögren space at the moment. But it can be something that we can. I'll be speaking about another project later on that we're launching today around where future Sjögren's research should go, and we'd welcome you submitting a question like that into the pot for that. Of, like, what we could look at in the future, definitely.
Okay, thank you.
Natasha, do you have any thoughts on saying?
I think that's what I was kind of hinting at when I showed all that lupus data, because they are that bit ahead, and it does mirror a little bit Sjögren's. There's definitely a move towards what I do, a lot of adolescent and young adult work. There aren't a lot of adolescents and young adults with Sjögren's, but a few. And there is a move towards what they call life course research. So, you know, starting looking at people early on and then following for many, many years. And I think, it will be important that work is done, but we're not there yet. Work for you guys.
Yep.
Yeah.
Time to roll up the sleeves. Yeah, we have another question here. Yeah.
It might be a silly question. Use this one. You were saying about the three groups, A, S, G, D, and I'm just wondering, I've seen a group A and group B. Do they still use that for SJD? Group A and group B? I'm just wondering, do you know what I mean? Do you mean I think there was a group A and a group B within CJD. Do they still use that terminology?
Oh, is it SAA and SASSB? Is that?
Oh, yeah, that's it.
Yeah,
Yeah,
yeah.
that's what I mean. Yeah, SSA, SSB. Do they use that terminology still? Or, you know, when they're talking about the 3 types of SGD, is that new?
I think it's Row and La, SSA and SSB.
The only place I saw A and B was that the other name for anti-Row is anti-SSA, and the other name for anti-La is anti-SSB, but we never subdivided the patients per that. I wonder, that's not it? No? Would it be seronegative and seropositive, having the antibodies and not? Basically having the antibodies or not having them. Maybe that's what it means. Not sure.
I think I might be just confused. I was thinking about 3 different types of SGD and linking that in my head with A and B.
We're done? We're okay? Sure.
Yeah, excellent. Thank you very much. There is a couple of questions kind of building along kind of what we'd spoken about there around, is Sjögren's hereditary? I suppose, would you mind trying to address that for us, Natasha? Or
so I did mention genetics a few times. So there are certain conditions where a single gene will cause them. So you'll probably be aware of like cystic fibrosis, where a definite gene, you get 1 copy from your mother, 1 copy for your father, and then someone gets cystic fibrosis. So these type of conditions, there's 1 gene that causes it. In Sjögren's or lupus or rheumatoid, genetics play a role, but they're what we call polygenic. So poly means many. So lots of genes might add in a tiny little bit, and then it adds up. But healthy people that don't have Sjögren's can also carry these genes. So it's kind of the sum total of their input and environmental factors all together. So it's not that there's 1 gene that has given you Sjögren's. It's a lot more nuanced and complicated. So genes are there, but we can't test you for them. And we can use them for research. They're very interesting in that way, but we can't test them in the clinic. They wouldn't be useful. So we very rarely, I don't think I've very often seen like a mother and daughter both having Sjögren's, but you will see little hints in the family, and it's usually a female relative, like an aunt with rheumatoid, or thyroid disease. That's very commonly seen in a family of someone with Sjögren's. So you can see these hints of other autoimmune diseases, but you wouldn't find like 5 siblings all together all having Sjögren's, because it's a different type of genetic signal. Just to give an example, can anyone raise their hands if they have a relative with rheumatoid or thyroid disease? Yeah, so it's more than probably half the audience. So that's the sort of thing we'd see. I don't know if you've seen anything similar or different.
No, I hadn't. I suppose I's been so, they come with Sjögren's, and often there isn't as much of an overlap, so it doesn't pertain much to our clinical environment, no.
Great. And then just maybe to change tacks slightly, kind of a couple of questions around kind of just the amount of education that is done in kind of medical schools and other healthcare settings around Sjögren's. What would people's experience be of the amount of time that's kind of devoted to teaching around Sjögren's within medical school, dentistry, etc.?
Would you want to go
and how do we make it better? How do we make it better?
That was a great question. I only, just through my postgraduate learning and my PhD, it was probably a very short exposure or teaching point really when I was doing my medical training, my general medical training. I'm kind of hoping that as events like this happen more, that maybe certainly in the postgraduate teaching environment, amongst specialist training, it increases as well. But it was just through my PhD and my research where I became more knowledgeable about the condition. What was your...
So definitely in medical school, there will be a series of rheumatology lectures. they do focus more on rheumatoid. I really am not against the rheumatoid people, but they will focus more on inflammatory arthritis. There would be probably one lecture on autoimmune connective tissue diseases. So you'll have literally a half an hour, 40 minutes, where lupus, Sjögren's, systemic sclerosis, myositis are all lumped in together. And if a student misses that lecture, that's it, you know, which they could.
Understanding the differences.
Yeah,
like you
yeah.
said yourself.
So it's minimal. It's probably a 1 hour lecture. I'm the clinical lead for rheumatology teaching for Trinity, so I'm responsible for the St James's medical students. So I have a bias, obviously. So we would give tutorials to 4th years, so they're fairly far into their training, and again, final years before their final medical exam. And again, a lot of those lectures are focused more on inflammatory arthritis. That gets the headlines. But I do the autoimmune connective tissue session, so I give as much airtime to Sjögren's as the other conditions. But that's just because I happen to be there. So I'm saying maybe the Trinity students get a bit more Sjögren's information. But I'm sure Beaumont Owen is flying the flag. But it's minimal, unfortunately, minimal.
Yeah, we try our best, but we're given 3 hours to teach them all of rheumatology in undergraduates. So it's tight.
You only need 2 hours for Sjögren's.
Can I just come in?
I think there's another question. Is there?
Sorry, just to follow up on that. SYNERG-IE currently has a healthcare professional survey open at the moment and is asking about, it's for primary care, but we are asking about minutes, hours dedicated to Sjögren's as part of their training. And then we are also going to be undertaking a curriculum audit of how Sjögren's is taught in different healthcare professions across Ireland. So we will hopefully, this time next year, be able to answer that question a little bit more definitively.
Yeah, great. Thank you very much, Nikki. I think there was a question from the floor. Did I see, Mags?
Yeah, I just wanted to ask, was there any connection between the Epstein-Barr virus and Sjögren's? I've been told there is.
Do you want to take that, Natasha? I think there's a lot of interest in it in the lupus world at the moment, and I suppose it's probably a permissive step in that there's a suggestion that it causes infection with Epstein-Barr causes some of your B cells to become more active, but it's definitely more a research question still at present. I think we're not sure. Would that be fair to say, Natasha?
Yeah. Yeah.
Epstein-Barr virus. Epstein. Yeah. Are there any more questions online, Frank? Sorry, there's one more question here, I think. Sorry.
Hi, I'm just wondering, what is the pathway, if you can explain, from Sjögren's that leads to the muscle weakness? Like, you know, the way the eye was explained of how it ends up with the dryness, I can never understand how the Sjögren's actually comes down and causes the muscle weakness. I'm just looking for a little bit of clarity on that.
So that's probably a very long answer to that, and it wouldn't be one single thing. It's likely multifactorial. So there would be a very rare cause of muscle weakness is when Sjögren's overlaps with myositis. So that would be vanishingly rare. The most common muscle weakness is probably linked to the fatigue, which we saw is such a predominant feature in Sjögren's, so that would be one thing. If you're very unwell with any condition, any illness, you can become deconditioned, so you're exercising less than you did before, and that can appear as muscle weakness. I mentioned thyroid earlier, so absolutely that can be linked with muscle weakness, and joint pain as well can kind of link in. So there are many things. Most likely it's not one thing, it's likely to be multifactorial or lots of things adding into that.
Great.
But I think the fatigue is probably a big component.
Perfect, and I think we're probably coming to the end, and just in terms of timekeeping, but one last question is around kind of outlining their fertility roadmap for a woman with Sjögren's. What should they need to know? Is there an impact on time to conceive?
So my impression is overall fertility shouldn't be reduced necessarily in Sjögren's, but there are pregnancy considerations. A lot of patients with Sjögren's present, when fertility, in their 50s, 60s, where it's not an issue for them at that point. But I do have quite a few ladies in their, late 20s, 30s, 40s with Sjögren's, and I do counsel them about pregnancy. So the big thing would be about the Rho and La antibodies, that there's extra monitoring you need in pregnancy. And now the complications with those are really, really rare, very, very low prevalence, but patients should know about them, and their obstetrician will be aware of them. So that would be the main thing. But fertility itself is not greatly reduced in Sjögren's as compared to the general population.
Excellent. Thank you very much, Natasha. I think Frank may have a question down the back from online, and I think there might be one other question then from the room as well.
So question online, very much focusing on, I suppose, how the healthcare service delivers care. Someone who said, I've quite a few different consultants and teams and find they're only interested in problems relating to their body part. I feel like past the parcel these days. And maybe thoughts from the panel on who should coordinate care and, I suppose, maybe take responsibility for that. So maybe how can we look at the healthcare system and see how we can improve experience of care?
It's the $1 million question. I mean, I would love to go to work and be in a clinic with an lovely ophthalmologist, have dental input, have neurology input. That would be the ideal. Really, I would love that, but it does not exist at the moment in Irish healthcare. These kind of multidisciplinary clinics, and it would be the absolute ideal, but unfortunately it doesn't exist. Who should coordinate? Well, in Ireland, it generally is the patient's GP, because they're the primary physician, but I know that's difficult. I find for some of my patients, I feel like I am probably coordinating care. It depends where the patient has come from. They may already be attending ophthalmology or other specialties, but if they aren't, very often I will refer on rather than asking the GP to. But it's very broken, and there isn't a set pathway of how this happens. But maybe, Eileen, you'd give a better answer of your experience of.
Thanks, Natasha. Yeah, I think it probably came up through the Photo Voice exhibition as well, but there's a real frustration amongst Sjögren's patients that their condition isn't being holistically managed and that they're not being managed as a person. Because as we know, we've seen from the Photo Voice exhibition the amount of time and energy and management it takes to manage this condition, to keep up to date with your appointments, to try and figure out your symptoms. And generally, it is the GP that probably most people go to. As we know, some GPs are probably better informed than others, and this is why we're trying to raise awareness today. But there is a real frustration because it impacts on your quality of life, your day-to-day, your mental health. And it is true that sometimes, patients are being managed by the sum of their parts and not as a person. And I think, hearing about the patient voice today is important. And, I think that we need to be managed as a person and not just the parts that are affected by Sjögren's. It's really important.
Great. And I think we've one final question down the back. Just before we get to that, there has been a couple of requests around, will the slides and presentations be made available? And they will be put on the SYNERG-IE webpage for people who want to review them at a later date. Sorry, final question at the back.
So I was diagnosed with both. I know you were saying technically they're not related, or do you have the two? But I actually was diagnosed with the Sjögren and the lupus. But I'm just wondering, when my lupus is flared, I end up with terrible stomach issues, and my doctor just keeps fobbing it off. Oh, it's just maybe the start of IBS or something like that. Are they related? Stomach issues.
Well, lots of patients. It's very common for patients to have gastric issues in autoimmune diseases. but then gastric symptoms are very common anyway, even outside of autoimmune disease, so it's hard to say. I certainly, if it was a persistent problem, would kind of try and encourage your GP, if they're not able to get on top of it, that they might refer to a gastroenterologist that might do an endoscopy and have a look down. But gastro symptoms are really, really common, and they are present in autoimmune patients. So if it's not settling, I think it would warrant a further look.
Excellent. Thank you very much. And we might draw the panel discussion to a conclusion at this point. And again, just to say my thanks and appreciation to all the participants. I think we might just briefly move on to Nikki now, I think, who is going to talk to us a little bit more about some of the future work that is being planned in terms of requesting your assistance in developing some priorities for the future. Thank you very much.
Hi everyone. I just want to say thank you so much for all the engagement and just discussions this morning. I've really enjoyed it, and I know me and my colleagues on the SYNERG-IE team will just have, there's a lot of food for thought about the conversations I've been part of this morning. So just want to reiterate thanks from all of us for your attendance in person and online today. So this is just a bit of a different session in the sense that we've kind of talked about research that's been done. I just want to kind of flag with you some of the stuff that's ongoing, and that's something that's being launched today as well. And where we need your help. Michelle very clearly kind of said we will need your help this morning, and I'm just pointing you to some of these areas. So today marks the official launch of the Sjögren's disease research priority study. This is a really big milestone for us within SYNERG-IE, but it's also a milestone for Sjögren's disease. It's the first time that people living with Sjögren's, their families, carers, and then the healthcare professionals who care for them will work together to decide what are the most important questions that needs to be answered by research in the future. So I think a lot of the questions that came up in the session just gone are exactly that, like noting, we can see where some of the gaps are in research, but we want to kind of formally document them. So we're using an internationally recognised method, and it's a bit of a mouthful. No one has to remember this, but I'm going to say it anyway. It's called the James Lind Alliance Priority Setting Partnership. And that is, the James Lind Alliance, basically, they advise us, and we have an advisor who she advises, obviously, but she just makes sure that we are doing the process exactly as it's supposed to be done. It's already being used across multiple diseases and conditions around the world, and its purpose is to make sure that future research focuses on what really matters to people who are living with the disease or the condition, their families, and then the healthcare professionals who treat them. So it's not just about what researchers or funders happen to be interested in. And of course, SYNERG-IE has been informed by Sjögren's Ireland and patients already, so this research is very much, our research is very much informed by patients and healthcare professionals, having people like Owen involved, but we want to make sure what happens in the future kind of carries that forward. So at the end of this process, we will have a top 10 list of priorities for future research and funding to address across the island of Ireland. And it's very much a partnership effort, so we have a steering group guiding the research. Many people in the room are involved in that. It's made up of different people across the Sjögren's community in Ireland, and it's across Ireland, so it's an all-Ireland approach that we're taking, Northern Ireland included. And that balance of experience is crucial to this process. So patients, carers, and clinicians have equal weight in every decision that's being made about this. So what happens in a priority setting partnership? I won't over-egg it too much, but I do want to just make clear to you that we may be coming back to you at multiple points, just asked, and you may wonder why you've filled in a survey already, why are we asking you to do it again? So I'll just kind of guide you through that. So we're going to launch, we're launching the first survey today, where you will be asked to input just anything that you think that research should address. And then we're going to go and we're going to review and we group all of the submissions. We remove any that have already been answered by research. So if there's something that's definitively been answered, we'll remove that from the process, but we'll still keep a record of it. And then we'll run a second survey where everyone who answers it can rank the remaining questions. So if you think something around the menopause is like the most important thing to answer, then you'll rank that one and you'll so on. We'll give you the list of questions that have come from the first stage. And then finally, we'll hold a priority setting workshop where equal numbers of patients, carers and healthcare professionals come together and agree the top 10 research priorities for Sjögren's disease based on Ireland and Northern Ireland data. So when that work is done, then we'll publish the results and we'll share them widely. And the idea of everything that we do in SYNERG-IE isn't to have our research sitting on a shelf gathering dust. This is very much an applied research programme. Our aim is change. So we'll be sharing the results widely, and we'll be pushing researchers and funders to address those research questions that will have been identified as the priorities. So what are we asking you to do today, or up until the 30th of January when the survey closes? So your voice really can matter here. It can shape what gets researched next. If you've ever thought, and I think from the previous session we got a sense of you are thinking about these questions already, why don't researchers study this? I wish more could be known about X, Y, and Z. Then that's exactly the type of question that we need. You don't need to put it in as a research question per se. That's our job to translate what you put in into research questions. If you have anything that you're uncertain about, and we have some guidelines around what that means in the QR code there. But it could be questions like, what's the role of nutrition in managing Sjögren's? What are the links between Sjögren's and menopause? Any of those types of questions. The survey takes about 5 to 15 minutes, depending on how many questions you submit. And you can take part in several ways. So predominantly, we're running the online survey. It opens today. It runs until the 30th of January. If you struggle with filling out a survey online, you can contact me for a print version, or we can do it over the phone. So we want to make sure that it's accessible to everybody. If you can encourage your family members, anybody that's involved in your care, to contribute as well. This is about patients, family members, carers, and the healthcare professionals that are involved in Sjögren's disease care. And we will be pushing it out as strongly as possible amongst our own networks as well. So this is really a chance to shape what gets researched next. So we would just encourage everybody to scan the QR code or contact me if you want to fill it out in a different way. So that's my ask number one. I've got a couple of asks here. So the next one is, some of you've probably already, I think many people have already filled this out, but we're currently doing a patient experience of healthcare survey, and that's the QR code there. It's open to adults in the Republic of Ireland, and it asks questions about you, how Sjögren's affects your life, your medication, and some of the expenses associated with Sjögren's. It's really important that we get as many people as possible completing the survey. So lots of people have started and haven't finished, and I would just urge you, if you haven't yet done it, or if you haven't finished it, we would be really grateful if you could complete it. So the greater number of completed surveys will ultimately make our research findings stronger and more powerful. So, and we have our PhD scholar Jessica Bennett at the back of the room there. She's doing a great job getting people involved, and she'll be doing the analysis of it. But it closes in 2 weeks, so I would just ask everybody to have that, to participate and respond before then if you're so inclined. Another part of the jigsaw, so these are all different parts of the jigsaw that are going to ultimately, we will hope, improve care for people living with Sjögren's. We're exploring the experiences of living with Sjögren's in Ireland. So we've already got the photo voice study. That was a very in-depth study of 11 people. we're trying to get more variation here and understanding what it's like to live with Sjögren's. And we're inviting people in the Republic of Ireland to share their experiences of living with the disease. This is an interview study. It's going to take place online and take approximately 1 hour. And again, it's another one of our PhD students, Katie, who's at the back there, who'll be doing the interviews. And you can contact myself or Katie if you have any interest in getting involved in the research. And Alana designed some lovely bookmarks there, which I hope everybody has. But the details about all of these studies are on that too. So again, if you're interested in taking part in an interview study, please do contact us. And then we have a healthcare professional study that's closing in 2 weeks as well. Claire, our postdoctoral researcher at the back of the room there, is running that. And this is it's specifically for primary care healthcare professionals, GPs, dentists, pharmacists, physiotherapists, and optometrists. We've got a good response rate already, but we are just doing a final push now in the next 2 weeks. We really, really want to get as many healthcare professionals in these areas filling out that survey. Again, greater numbers can just lead to more powerful responses and make sure that our research is taken as seriously as it should be and it deserves to be. So that is everything to do with the future research studies. I don't know if anybody has any questions or comments about anything that we're doing or anything that I've just mentioned now. But if you do, I'm here for lunch, so you can ask me or the team about any of the studies that are ongoing. So I'll leave it there and I'll hand over to Mags then. Thank you very much.
Before we have our final remarks, we're just going to say thank you to the team who put all of this together. It really was superb, cooperative event. There are more questions than answers, as you can see, but it is lovely to be asked to provide the answers, to provide the questions. If you haven't met Deirdre and you want to be in our WhatsApp group, find Deirdre. We've had a lovely lesson in our first word of Swedish from Monica Sjögrens. And I am going to now hand over to one of the women who started the entire patient-physician, patient-professional connection. Eileen, please come and close us out.
Thank you, Mags, for that lovely introduction. And on behalf of Deirdre, Grania, Monica, it's a real privilege today to deliver the closing remarks. Earlier this year, an important milestone was reached. Sjögren's syndrome became Sjögren's disease. And this really matters. It matters because it reflects the serious, systemic, autoimmune nature of this condition, one which can affect multiple organs and every aspect of daily life. It's also recommended now that we move away from primary and secondary Sjögren's and instead refer to associated. This acknowledges that while Sjögren's can occur alongside many other autoimmune diseases, it stands on its own as a complex and impactful condition. With this in mind, today's knowledge sharing event feels especially meaningful. Events like this give us patients the chance to learn more about managing our condition, to hear about the ongoing research, to raise awareness of Sjögren's disease, and perhaps most importantly, to meet in person and to support each other. We're incredibly grateful to the RCSI team who made this possible again today, Nikki Dunne, Alana Drury, Michelle Flood, Owen and Frank. Thank you again. Your commitment and your partnership are really very, very important to us all. I'd really like to thank our speakers today. I think we all learned something and, it gives us hope, I suppose, for the future in terms of not only clinical pathways, but, new medications and new treatment options with those of us who are living with Sjögren's. A special thank you to Alana and to Nikki for creating the wonderful Photo Voice exhibition And as you know, a small section is on display here today. It was an incredible project and a fantastic opportunity for our community to express a visual representation of how they feel living with Sjögren's. And for anybody who hasn't had an opportunity to see the entire exhibition, you can find it online on the SYNERG-IE website. We're delighted to continue partnering with RCSI's research team to ensure that the patient voice is heard, and we look forward to the outcomes of their research in terms of ensuring better clinical outcomes for those living with Sjögren's, but also highlighting other areas such as the financial burden that's carried by those who are living with Sjögren's every day. As Nikki mentioned, there's plenty of ways to get involved, and we at Sjögren's Ireland will share those details through our social media channels shortly. Finally, I'd like to thank everybody who came today and who joined us online for making this a really special and successful event. For those of you who are joining online, we'll say goodbye to you shortly. And for those of you in the room, we'd like to invite you to a light lunch which will be served outside. Once again, thank you everybody, and I hope that you enjoy the rest of your afternoon.
Sorry to butt in right at the end again. We have left some evaluation sheets on the tables for feedback, and we would really, really appreciate if everyone could just provide us with a little bit of evaluation and feedback so that we can maybe improve events and things and move things forward in the future. And finally, I'd really like to thank our sign language interpreters today as well. They did sterling work. Thank you.